Hello, Dental XP members. I'm Dr. Dong-Sok Son. I'm oral surgeon who works for Catholic University Medical Center. I'm very honored to have a chance to present my clinical video of sinus augmentation using hydrodynamic piezoelectric internal sinus elevation. My colleague referred this 53-aged male patient for the sinus augmentation alone in the right posterior maxilla and three-dimensional ridge augmentation alone in the right posterior mandible. The sinus augmentation surgery and ridge augmentation surgery were performed at the same time under the local anesthesia. The first section of this video will cover sinus augmentation alone using hydrodynamic piezoelectric internal sinus elevation. This technique was reported in 2008. This is panoramic image of cone beam CT showing extraction defect at the right posterior maxilla. This is cross-sectional view of cone beam CT showing very limited vertical bone height from alveolar crest to sinus floor at the site of first molar. After injection of anesthetic solution in the surgical field, crestal incision was made by using 15C blade in order to expose edentulous alveolar ridge. Periosteal elevator was used to expose and small curette was used to remove all granulation tissue at the extraction socket. Anterior and posterior vertical releasing incision was made to vestibular area in order to expose whole alveolar bone defect. New 15C blade was used to make periosteal releasing incision before bone grafting procedure. In order to make periosteal releasing incision properly and easily, I like to recommend to make periosteal releasing incision before bone grafting surgery, not after bone grafting procedure, because to make releasing incision is more easier when you make releasing incision before grafting surgery. And bleeding caused by periosteal releasing incision can be controlled during augmentation procedure. Please make sure that the buccal flap should be overlapped of the palatal flap before bone grafting procedure. As the first step of HPISE technique, 1.6 mm wide round carbide tip attached with ultrasonic piezoelectric device, which is called surgery bone from silpradent, is utilized to measure the exact bone height from alveolar crest to sinus floor and to break sinus floor at the same time. After breaking the sinus floor with a round tip, a 2.8 mm wide cylindrical carbide HP tip is used to enlarge the osteotomy site and elevate the sinus membrane using hydraulic pressure. This tip is final osteotomy tip to accommodate 3.7 to 4.2 wide taped designed implant. The round carbide tip is more advantageous to round diamond coated tip because the round carbide tip is much faster to cut the bone than diamond coated tip, and the lifetime span of carbide tip is much longer than diamond coated tip. The round carbide tip was moved in the rotational action or scraping action to access sinus floor at the site of first premolar. When surgeons approached sinus floor with this tip, surgeons can have tactile feeling to the sinus floor. So we can measure exact bone height from alveolar crest to the sinus floor at this stage. 12 mm bone height was measured at the site of first premolar, so a crestally approached sinus augmentation was not required. The same procedure was performed at the site of first molar. As shown on this video, sinus floor was penetrated easily without membrane perforation. After breaking sinus floor with round carbide tip, 2.8 mm wide HPISE tip was used to enlarge implant site and to elevate sinus mucosa using water pressure at the same time. HP tip was intruded slowly into the sinus cavity to elevate sinus mucosa. Please note that water is coming out from sinus cavity after elevation of sinus mucosa. HP's technique does not usually rely on bone compaction to elevate sinus mucosa, unlike conventional crestally approached techniques. In order to accelerate bone reformation in the sinus, autologous concentrated growth factors were prepared by utilization of a special centrifuge which is called Medifuge from Silpradent. These fibrin blocks were inserted in the new compartment under the elevated sinus mucosa. In order to facilitate bone grafting procedure, the osteotomy site was enlarged by using implant drill. When implants are placed at the same time, bone grafting procedure is usually not required. However, my colleague just asked me sinus augmentation without simultaneous implant placement. So, bone grafting was used for space making. Gel-conditioned mineral allograft, which is called Orthoblast-2, was grafted in the sinus. Totally 1.5 cc Orthoblast-2 was used. After sinus augmentation, the extraction defect and alveolar bone defect was augmented with a synthetic grafting material which is called vital bone substitute. Vital bone is a fully resorbable synthetic material which is composed of synthetic beta-tricalcium phosphate and calcium sulfate. According to some articles on Porter's vital bone, it is easy to use and can be controlled to the defect site. When the material has set hard, it forms an effective cell occlusive membrane for up to 3 months. So, collagen membrane is not usually required to cover the grafting materials. After completion of leech augmentation using vital bone, tension-free suture was performed. First, horizontal matrix suture was used to close the flap, and interrupted suture was done to close the wound without tension. This is a post-operative image of cone beam CT showing sufficient sinus augmentation. Even though only one osteotomy site was used to apply water pressure to elevate sinus mucosa, sufficient sinus augmentation was achieved according to the cross-sectional view of cone beam CT. As shown on this video, HP's technique is very minimally invasive surgery, so post-operative patient discomfort is very minimal. This technique requires minimal instrumentation, so surgical steps are very simple and surgical time is highly decreased. Unlike conventional osteotomy technique, this technique does not use osteotome. So, this technique is free from post-operative positional vertigo. HP's technique does not usually depend on bone compaction to elevate sinus mucosa, so membrane perforation from bone compaction is very minimal. Thanks to water pressure to sinus mucosa, the membrane elevation is generally elevated vertically and palatally, anteriorly and posteriorly, not localized elevation. So this technique could be alternative to laterally approached sinus augmentation. Thank you very much for your kind attention. I'm very honored to have a chance to participate in dentalxp.com. If you have any question on this case, please email me at this address. Thank you.